Great. So we'll start off with, can you introduce your venture and give a context of your hospital in?
Yeah, sure. So, Superhealth really started out of our own frustration as customers about just in general the lack of transparency when we go to hospitals. And as we sort of went down the path of trying to understand why that happens, we realized that actually the origin, all of those are symptoms. The actual problem is that the cost of healthcare delivery is very high, and it is high across the world, and therefore nobody in the world is happy with whatever their healthcare system is, right? US, God forbid, UK, long waiting. So on balance, we concluded that actually we have it pretty good in India in comparison to what's happening in the West. But across countries, the problem is the same, right? That the cost of delivery is very high. And then when we looked at that, we realized the cost of delivery is primarily made up of land, construction, devices, medicine, and people. These are the five broad components of healthcare. And what Superhealth is really trying to do is to try and build a model for India that is designed around what India needs and not so much around what I guess over the last 30, 40 years we've sort of learned from the West. Right? And there are few important distinctions that we at least feel is there. I think the first is that while India delivers the top 10, I mean, high quality care at 10% of global cost and all that, it is still expensive for people. Secondly, we are not the same age as them, right? Like India's median age is 28, right? And they are in the late 40s, early 50s. So the problems of a 28-year-old are very different from the problems of a 50-year-old. We are not a payer-driven system, right? We are a provider and a consumer-driven system, right? Our cities are not designed like their cities, which are generally much less densely populated in Europe, tiny cities. We have large cities. So why are we building destination centers beyond certain tertiary or quaternary things? So Superhealth really started from that, and we are trying to build a fundamentally new way to do hospitals where we can build them more efficiently. So today we build a hospital at about 75 lakh rupees a bed compared to 2 to 3 crores, which is what other people do. And a large part of that actually comes from AI. So we try to maximize the number of clinical people and minimize the number of non-clinical people. And even within the clinical people, we try to see how much of the, I guess, codified stuff can be done by AI systems. So with that, what we've been able to do today is that we are able to do some, kind of cool things, I have to say. We are able to deliver 99.5% customers today get zero wait time. So when they see the doctor, when they book the doctor, they see the doctor on time. We, are able to deliver fixed prices. So the prices at Superhealth don't change for the surgery, even if you have to stay a few extra days or some 6 more scans are required or the case gets more complicated, whatever it is, the price is what we say the price is. Usually 40 to 50% lower than what you would pay in a competing corporate hospital. And finally, which is I think equally important, we do things like magic discharge. So we have only clinical discharge because the price doesn't change. So as soon as the doctor says you can go, you can actually get up and go. Insurance obviously supports us a lot in this because we are already half the price they would have paid somewhere else. And all of this together does two very important things. I think the first is because of a clinician model of salary plus ESOPs in the company, our doctors actually don't have to deal with the typical corporate hospital sales targets and commissions and all. We don't have that. So our doctors only focus on the care. It only cares about what the patient wants. That's it. That's the only thing. So today we prescribe 50% less surgeries than the industry. For the same case, we have thousands and thousands of people who've reached out for second opinion. 42% of those direct cases had less. Have we told them they don't need surgery? In general, at Superhealth, for every 100 patients we see, we prescribe 50% less surgeries than them because people need less than them. It is not a concern. So that's really for us what honest healthcare is. At the heart of it, the idea is how do we, we keep saying this internally in a little bit of a lighter mode, saying that how do we free the doctor, to go back to being the doctor instead of all these other things the hospitals make them do. And how do we get technology to take over a lot of that load? And obviously, we are honestly very inspired by institutions like St. John's, who are really championing the cause of high quality care. We are in the neighborhood, so it's great. We try to do partnerships with you guys on when we get cases that we can't handle, so we can send the cases here and be sure that they're getting good care. So in a slightly longer way, I just want to make sure you understand what our attempt is. We are very young. We are like 6 months old, but this is what we're trying to do, and
Yeah. Thank you. So yeah, on a contrast, St. John's is a 1,800 bed hospital, right? We see about 3,000 patients who walk into our outpatients every morning, and they need to be seen within the next first 4 hours when they land here. We have our struggles with that, and we are hoping that we can use AI in different ways to kind of engage with these patients, especially many of them are coming from cities or villages from maybe 100, 200 kilometers away, because Bangalore sits at a junction of 3 states. So, uh, so very different scenarios, and this is where I think there's a contrast between two private settings, but one which is focused on a certain use case, and ours is a different use case. Now, Varun, you've built a facility where AI is the foundation,
Yes.
and not an add-on, right? So, what was the biggest human friction point you encountered when moving from code to the clinic?
Actually, sir, the hardest part really was actually it was not what you would imagine as clinician adoption or people adoption, etc. Actually, it was just rewiring our own brains, right? Because our system design is the following. So the platform is called Super OS, and what we did was we inverted the relationship between the software and the institution. So, you typically go to a hospital, and what happens is that your health system, as sir was saying, the data quality is poor because basically it is an accounting system, right? Like the work is still happening on paper pen mostly, and then some junior guy in the night has to do some entry, right? And this is happening in the best of institutions around the world because obviously the software was not designed really well. Healthcare kind of gets access to like baby software, not really very high quality software that you see in other institutions or other industries. So we deleted that entire thing and we started from a very simple principle saying that when you come to Superhealth, Super OS will hold your case. Okay, and it will take instructions from the doctor, and then it will assign actions to agents in the system. Okay, some of these agents are human agents like nurses, phlebos, technicians, runners, whatever. And some of them are AI agents, like the billing systems, like the booking systems, like the OT slotting systems, etc. Right? But SuperOS holds the case. So at all points, there is a consistent entity that has complete case knowledge, and it is able to surface relevant information about the customer at the right times. So we have this thing saying that AI system. So I'll give you an example. When you come to Superhealth for a consultation, because we built the rooms and we built the AI systems, we didn't want the doctors to spend time typing things. So we said, okay, the goal is zero typing. Okay, not edit, not like how to make typing easy, delete typing. The doctor should just talk to the customer, and we should figure out as a technology company how to make the prescription written and all that. So we realized the number one problem is that you're not able. Most people, when they build these AI systems, they actually put it into the computer, right? But as all of anyone who has been to a doctor, and of course every doctor knows that only half the conversation happens at the table, the other half happens at the diagnostic table, right, where the examination bed is. But the mic is not there. So if the system cannot hear, how will it tell you what to do? So when we built the room, we actually put microphones in the wall, knowing this is how it's supposed to be. We built the room for the right acoustic, so there is no echo. And then we built a system trained on Indian data, not because we use doctors' existing cases and so on. So it is fine-tuned not just for Indian cases, it is fine-tuned to how that doctor treats, because doctors have stylization. And then obviously it understands 15 Indian languages and stuff. So because of this, we have near perfect prescription because we have all of the audio. So now SuperOS knows the full case. So now imagine this is happening at every step. Our prescriptions are done like this. Our inventory is managed by the same system. So it knows what drugs are being given. The rooms are allocated by the system. The OT schedule is done by the same system. It also knows how long that doctor takes to do that procedure, because between doctors also these procedures take different amount of time. And since it knows all of this, it just writes a discharge summary, right? So what our goal is that how can we make it insanely convenient to do this, and then just show it to the doctor saying, does this look okay, right? And the doctor has the final word. So our goal is not to replace the doctor at all. We want to make the workload easier and easier and easier and easier and easier. And I think it was more a mental shift of us, the people building the system, that how do we imagine for zero input system? Because if you have zero input requirement, your data quality is very high and your AI system gets much better, right? So I think that, sir, has been the biggest challenge. Obviously, as you highlighted, We are a small sliver of the overall pie of healthcare. As you said, sir, you do about 3,000 appointments a day. We do today about 500, 600 a day only. We are a 50-bed hospital. We do only 50-bed hospitals, and we want to just do a network of these. So I expect that the differences and complexities that you guys will deal with be a little bit different. But at least if people start thinking like this, it can happen, and it can only happen if the hospital becomes the technology company. Don't let technology be something that happens to you. Be the technology company as much as the healthcare company. I think this is the only way, because no amount of external technology company can understand the nuances of what doctors do every day. It's very, very hard. I mean, enough people have tried. You all have been subjected to it.
Thank you for that. I think that brings us to this point that the Major General Atul pointed out about innovation. I mean, as part of SCI, innovation versus restraint, and this is an example where you're innovating as well, and to ensure that the friction is reduced in health systems. And we really dream that this would really get into primary care, which is our dream in India, to really get this kind of technology tested in perhaps regulatory sandboxes. Coming back to St. John's, we're a teaching hospital, and we're seeing an increased use of LLMs.
So do you mind if I may ask you a question, if I may?
Sure.
I am very curious, sir. As an institution, see, we are a hospital. We already hire great people. You have already trained, right? But as you think through as a teaching hospital, right, and you're looking at training the next generation of doctors, these are individuals who are sort of growing into the AI world, rather than people like me who are sort of like were here before AI showed up, right? And then we are trying to scramble to keep up and learn. So as a teaching institute, how do you sort of think about introducing this or incorporating this into the curriculum, or getting the doctors sort of ready for it so they understand and they can actually shape the direction of AI, rather than just some, for lack of a better word, random tech folks saying, hey, we know what doctors want. They don't know, I can assure you.
No, thank you for that. And being an educational institution and also training doctors, we've realized that AI is racing ahead. People are using GPTs left, right, and center, any GPT that comes. And there's this thought process in St. John's where we should use GPTs that help doctors get the information they need without this concept of cognitive offloading. Because in a medical institution, it's very easy to ask a GPT saying, tell me what to do, and you just offload it. And I think that's where we're trying to strike a balance, where we work with solutions that can make it's intuitive, but also pushes questions back at you rather than just giving you answers, say this is the solution. And as teams, my colleague Dr. Burgis and teams have actually since COVID have been working on clinical pathways. We worked with various groups and started building those clinical pathways into what is now developed into a RAG model solution, which can actually go into primary care. We've working with a startup incubated with us, but we've worked with folks from across various other universities in the US, etc. But these are the kind of ground-up solutions that we've been building. We've even evaluated very large, these decision support tools which are available. For example, the Clinical Key AI from Elsevier. We've tested it in St. John's. We gave it to all our clinicians and said, use it and see what kind of responses you're getting. But sometimes it's not contextualized to our country, not contextualized to primary care setting. Let's say a doctor in a primary care doesn't have the necessary drugs, and you ask the LLM something, and it gives you an answer which is typically textbook-like. It doesn't work.
I think, sir, one other thing that I have noticed, as you're saying, right, is in the world there is this narrative saying that, oh my God, like they're going to replace doctors. I think, first of all, you don't have enough doctors, so let's first fill that. I think very often there is this. What I have found is that we have this, I think, incorrect belief that articulation is intelligence. Right? Like just because somebody speaks really well, we assume ki banda smart hai. I think that is getting transferred into AI, because a lot of times what AI systems do, especially the GPT systems, right? They're basically telling you synthesize Google search results effectively. right? There is nothing in there that you couldn't have Google searched enough to find the answer yourself. And I think that's the second fallacy of AI that I find, very, very superficial in the conversations, that information is not care, right? Like whatever you were going to do with your MRI report or whatever, and I have done it also, like you're saying, I have also put my wife's hands MRI into that and say, okay, what is Grok going to say and what's ChatGPT going to say? But ultimately, we had to go to the orthopedist to get the care, right? And I find this, this is a very sort of like software will eat the world type of mentality that a lot of us in the tech world have been living with and have been sort of inoculated into, right? And generally destructive in healthcare. And therefore, I was curious, how you would be equipping the doctors to sort of get onto the same level playing field, I guess.
Yes.
Um,
That's where we now have committees within St. John's trying to work towards this, from the education, from the research, from the innovation side, kind of brainstorm and work with collaborators to solve these problems. But having said that, one of the things is to improve efficiency in a healthcare system, in which you've demonstrated. For example, do you have a billing department, for example?
no.
So this is a hospital I've heard which doesn't have a billing department, whereas,
So we deleted a few departments. We deleted the registration department. We deleted the billing department. We deleted the admission department. We deleted the insurance department. Instead, what we did was we said, um, so the registration we deleted basically because of a philosophy, which was that when you come to the hospital, you're probably sick, right? Like, fair assumption. So maybe we shouldn't make you stand in a line. That seems like a fairly bad thing. So we have a really great subscription program called Superhealth VIP Pass. It's 4,000 rupees a year. It covers a family of four. And you can access the doctors as many times as you want in person. You can come and meet the specialists or whatever. And any test that is prescribed by our doctors, we cover it. So if my doctor prescribes you a MRI, we cover it. You don't have to pay for it. It's 1,000 rupees per year per person. So it's like, I mean, as affordable as I can make it. So people basically book the appointment and come, and we have zero wait time. So we have 55% appointments that actually start a little before time. So we have negative wait time. We have figured out how to get people to come on time in Bangalore, which in itself is an achievement, I feel. But that that, sir, allowed us to delete the registration department. We put a cafe there. We do really good coffee. You guys should come and try it. But like, अभी जगह बच गई, क्या करें यहाँ पे? So we put a cafe there. We also then realized that the billing is a problem, because the billing basically means that you don't know what things should cost, and we're like, well, we are the hospital, we should be the experts at this, so we should know what it's cost. So we fixed pricing. So what we did was we basically built a OT allocation automatically. So it'll figure out what is the type of surgery. Is it a sterile surgery, semi-sterile surgery, septic surgery, and then it'll schedule it accordingly so that cleaning time reduces, it monitors it real time. So it does all of the operational stuff. In recovery, we currently have three things live. First is the monitoring system, like I talked about, and we are now trying to see how this can get extended to home care as well. So we are building certain basic devices in house to see how can this be tracked post discharge. The second thing we do is, what we call this is built for orthopedics. So when you do a knee or a joint replacement in Superhealth, we built a Vision AI system that actually does a baseline range of motion before you do the surgery. And then as the surgery completes and post that, we keep monitoring it, because we provide the physiotherapy as well in the hospital and at home. It's not an outsourced service, because you paid us to walk again, right? Like, not for knee surgery. At least that's our position. So we provide the physiotherapy, and the physiotherapist basically keeps doing the physiotherapy, and the system keeps monitoring how much range of motion is in your shoulder or in your knee or whatever it is. And we have a defined protocol by our orthopedics department that prescribes what should happen. And as that happens, if it happens, great. If it doesn't happen, then it alerts the physician or the surgeon who did the knee, so that if something has to be checked again, can be checked. The third thing that is live today is wound analysis, so suture, because you want to solve for surgical site infections and all that. So when you go home and you change your dressing at home, right, if you want to do it at home, you can just take a picture of that area, and our systems will analyze that and tell you if the wound is healing as per what you want. The only thing we're not able to do right now is basically skin temperature, right, because that obviously has some impact on how the wound heals. So now we're trying to work with some suture companies to see if you can have sutures that change color by temperature. So then that camera phones can just see, and then we can figure that out. And then if we feel there is like loosening of skin or of the sutures or some infection risk or some pus or whatever, it'll actually tell your doctor who did the surgery. It'll tell you, but like what are you going to do about it? So they'll call the doctor. The concierge team will actually call you and say you need to come back in, so we can actually intervene at the right time. So these are early stages, but these are some of the things that we are building out as part of our recovery care systems to help take the care beyond the hospital. And at least what we find is that usually for many people, and again, it's been early days, these are some things that materially improve care, materially reduce re-exploration of surgically, and that obviously helps build better outcomes and lowers overall systemic cost.
Sure. Thank you for that. And alluding to what Major General Atul mentioned earlier about responsible AI in practice, with all this innovation and actually putting into practice, how was your organization implementing this whole accountability and explainability requirements into the framework?
I think so that's a great question, sir, and it's something we worry about a lot, and we have thought about it much before, when we were building this out. A lot of the stuff in Sahi. So I think the first is the framing for us is very different from a typical AI or a technology company, because we are as much a hospital as we are a technology company. So our core position is how do you help the clinicians and how the clinicians can help shape the system, rather than this is something that is just happening to clinicians. So obviously we have that. The final decision at all times is with the doctor, and nothing happens unless the doctor approves it. This is a core design principle for us. And there is a little bit of a philosophy behind it that, there is a lot of belief in AI and what it can do, and that's great. But fundamentally, AI cannot create new knowledge because AI is only trained on human knowledge. A lot of the instinct and heuristics of a doctor's diagnosis is not trainable data. Right? It's not written anywhere. Right? And so till that becomes trainable data, I do not believe AI will be as good as the doctor. I mean, you have a lot of survivor bias in AI where, few times it gets something right and someone puts it on Twitter and then the whole world takes over saying, oh my God, this is great. But how many times did it get it wrong? Who's recording that? Nobody, right? It's kind of like entrepreneurs, right? Like 1% succeed, but everybody wants to be an entrepreneur because no one talks about the 99%. So it's kind of like that with AI right now in healthcare. So we have designed it from that as the core philosophy. So the second thing is that because we built all the systems ourselves, we've built 100% observability in that, right? A lot, pretty much, not all of it, but a fair amount of it actually are SLMs that we have designed to run on device, so that we can sort of escape the vagaries of wireless internet. That almost never seems to work somehow magically inside hospitals. So the language systems and so on can actually happen on device, a very large part of that. And then third is that, from a safety standpoint that Sahi talks about a lot, normally what we find is that in healthcare institutions, the case analysis is post fact, right? And usually sample data, because obviously it's not humanly possible to do it. But what we do differently is that we actually do 100% case analysis real time. So as the consultation is happening, basis the protocols defined by the doctor, SuperOS is real time assessing this, saying that how is the consultation going, and it is not just assessing it clinically, it's also assessing it, what is the interaction ability. So it'll also give an assessment of, did the patient understand what our clinician was trying to explain to the patient, because it tries to triangulate that basis what the questions the customer asks. And then if it sees significant variation from the SOP created by that clinician only, because it is tailored to the specialty, it will actually flag the clinical team real time. So they can do something immediately at that point in time rather than 6 months later retrospectively. And we do this for 100% of the cases, and we do it real time. I mean, near real time, like within 60 seconds of the thing happening, which is pretty close to real time. So we found places where, we were able to actually elevate something from an ophthal consult to a cardiac consult, because it was able to say that, while probably it is not, but there is a 5% chance that this might be the case. So we routed the patient through ER and got them to the cardiologist, and cardiologist could see what the thing is. We have seen some good outcomes. It's a little anecdotal, but these are some of the things that we do, sir. And Obviously, we build all the logs in-house, all the data is in-house. There is no, and even when we use open source LLMs, we actually host them ourselves. So it's our environment. So there is no like calling home top type of situation. So I mean, directionally, we want to do as much of this as possible. This is what we have done so far, which in general gives me, I think it's better this way if the hospital only does it, because then there is less chance of data going out into other areas which, you know, probably you have less control over, let's say.
Sure. There was a question earlier about the larger picture about the National Digital Health Blueprint, which is the Ayushman Bharat Digital Mission, where finally patients should be able to move from one hospital to one healthcare system to another. How open is your operating system, or is it designed with these kind of plugins or APIs?
Active conversation with ABDM to see how best we are able to integrate this, because so there are two parts to this, sir. One is, do we want SuperOS to be integrated with ABDM? 100%. We want to do it. We will do it. But more importantly than that, as we stabilize the systems and the systems start working at a little bit more scale of maybe 3-4 centers, we would love to see how this can get open sourced and everybody should use it. This is not something that we want to do as a proprietary system. We therefore built all, by the way, everything I'm telling you works in the browser. It's not like to install any proprietary thing. You can just like log it. Like you could deploy this today. Insane. I mean, complexity of operations, I'm not commenting, sir. But I'm saying if you want it technologically, the total sum requirement is I'll give you a login ID, you can open it on your computer and you can use it. Like that's what is required. That's it. Right? So we're trying to build it with those ethos, saying that how can we make this available more generally across the country to anybody who wants to use it. It's not this part of the thing is not a commercial endeavor for us. If we can build great technology that helps clinicians, that helps our country, that's what we want. That's why we started Superhealth. I mean, I'm not going to complain if we become a very large multi-billion-dollar company. I'm not going to complain about it, but that's not the goal. So the goal is, how do we fix healthcare in the context of what India needs? And that is a multi-layer problem. We are going to solve the distribution problem with hospitals and the technology and the people problem. And then as we mature, hopefully we can reverse integrate into the devices piece, because obviously there is a lot of Western margins we are paying, which we don't need to. Our country doesn't need to pay that. China is not doing that, for example. Right? If you go to China, I was there in January and I saw that they are doing a lot of this stack themselves. And because of that, they're able to administer healthcare at a cost that makes sense. Right? And therefore the government is able to do it. It's not just an outlay issue, as sir said, that it's also an efficiency of deployment issue, which is A, is the money reaching, but B, why can't we just build this ourselves? We can, right? We should, and I think there is a lot of programs the central government has done in terms of incentivizing med devices and stuff. So, if there are people who are thinking about what should they build next, like do something in med tech, like build an MRI, build a CT, like, I think India needs to do that. So at some point we will get there, but this is what we'd like to do.
Thank you. I think, do you have any other questions for me?
Yes, sir. I have a whole list. I was a teaching institution. I was kuch to seekh ke jaunga main. Sir, one, I saw that, there is, for us, I guess it's a little bit simpler because, we had the luxury of starting from scratch. But, as you lead this institution and you take it into the AI era, right, what are some of the complexities that you envision in transitioning these systems to now a newer age, more AI-based systems, and how does the research team here think about some of those?
Our problem is in building that foundation data layer, and we've always struggled with it. Most hospitals in India have gone through several HIS changes, and it's disruptive. So we are in the process of one more change here at St. John's, but once we do that, we are integrating. For example, our entire ERP is running on SAP, but we're now integrating the next gen softwares into that. But once we have that layer, as I said, we are a hospital which we have about 3,000 people employed, right, for about 1,800 beds. It's a large operation. We need to manage 1,200 nurses and roster them across 6 different crazy shifts. Some come at 4 hours in the morning and 4 hours in the afternoon. So how do we manage that? how do we know which ward is full, which ward is not full? So, and of course, our outpatient is a different category of, being a teaching hospital and being measured by NMC standards. Every footfall has to be measured. And of course, the government has mandated that every footfall should be ABA tagged. It takes 15 minutes to do one ABA registration for someone who's coming from a bus and landed in our doorstep. So this is where we're looking at how can agentic AI be, included into our systems. But we are struggling with some of these challenges. We are struggling with the whole data pipeline challenge, making sure that we're interoperable. But also at the same time, we're building in coding systems. We are, of course, our teams have built systems for ICUs about a decade ago using SNOMED coding, where we worked with the Society for Critical Care Medicine. So we're familiar with what needs to go under the hood, but this is where we're hoping to build systems that ultimately have data that's meaningful and aspire to use, become systems like what you have developed that overlay under these crazy data layers underneath.
So just a follow up on that, sir. One of the things that we have seen be helpful, right, is this entire change of interaction layer, right, where typical software systems, there is a UI layer, there is an inference layer, and there is a storage layer. There are three layers. In the world of AI, the UI and the inference has become the same layer, and then you just have like AI and storage. How do you guys see some of that happening? Because for us, it's a little less complex because obviously the type of people who are coming to Superhealth are of a certain kind, and so language identification all is a little bit easier for us. But obviously, you're getting it from such a diverse set. So how do you look into that from an Indic language standpoint? I mean, we support 15, but obviously you probably need more than 15.
Yeah. So the government of India has developed several of these solutions already, and we're hoping to integrate some of those into our systems. But we have a challenge. To give you some context, as your patient interactions are usually one-to-one. In most other settings, including St. John's, there are 3 patients sitting with 3 doctors in the same room. That sends our voice a conversational AI into the bin, right? Our teams have worked in primary healthcare, and they've gone to the Ayushman Bharat centers or PHCs. There are 15 patients sitting around one doctor, and the doctor's just pinging each patient, and he's multi-processing. So this is where we're trying to see how can technology work at that level. For us, it's primary care first, and then, of course, how do we sort out similar things in St. John's? So I believe technology exists. I believe we have very smart people in India, and I'm sure we will solve it. So I'm really looking forward to that.
So one last question, if you permit me. Sure. In terms of, when you look at, this is a question more that I have, and we are, like I said, 6 months old, so some guidance would be awesome. One of the questions that somebody asked me, and I'd never thought of it like that, was that if you supply the answer too easily, will the doctor stop reading the suggestion and just hit accept? I had never thought of that, to be very honest, right? Because the last thing I've ever thought of doctors is lazy people. So like this is how it was a clinician only who framed it like that, saying, what if doctors get lazy? And I'm like, doctors lazy? I've never seen a doctor in my life who was lazy. but how do you think through that, sir? Because obviously in your case, because of this sheer scale, it's probably a lot easier, and obviously you have the benefit of longevity to guide us on this.
Yeah, so this is where we are hoping that technology that we will work with in the future, especially in primary care, is able to push the doctor to think. A couple of weeks ago, I was trying to push a few of our students who work in remote areas. St. John's has a mandate that anyone who does their medicine here does 2 years mandatory rural obligatory service in about 400 centers in the country. Now, many of these centers are so frugal, there's very little that they can do. And just to share a personal story, my daughter as well is right now in the middle of a forest in Karnataka, where there's nothing. And she has to deal with emergencies, or she has to deal with any other routine case that comes up. So there are some tools which we've been testing out there, and of course working with some of the other alumni as well. How do we use this technology at the edge without and I see a different challenge there because some of the doctors have a WhatsApp group right now. They're constantly pinging our senior doctors who are sitting in St. John's and trying to get some responses. But our clinicians are not available all the time, 24/7. This is where Agentic AI can come in and provide more contextual responses which are accurate. At least give them some guidance. At 2 a.m. in the morning, you have a snake bite. What do you do? Right. So I believe the technology will evolve, and we just have to bring together experts to finally address some of these challenges. And yes, doctors can be kept busy with AI.
Yeah, no, for sure. Okay, I mean, I have a ton of questions, but in the interest of time, I'll pick them up separately with you, sir.
Sure, thank you. And just as the last question, where do you see Agentic AI in your context in 2 to 3 years from now?
See, the vision we have for SuperOS really is how do you build a hospital that is doctors, nurses, and AI, right? Like that's it. How do you do that? There is a moonshot project that we kind of have, getting kicked off inside Superhealth, which is, around what we call surgical AI. So the core thesis is this, that the problem of spreading surgical excellence is not a hardware problem, right? Because clearly with Intuitive and SSI and others, the robot exists. The problem is it's run by a human today, and the human is the only one, and it's training and blah, blah, blah. I'm not even getting into the cost of the robot being, why is it $3 million when it should be $500,000, whatever. Separate problem. But let's say we figure that. The reason is because there is no neural net that can actually run the surgical robot, right? And the reason why there is no neural net is because the people who can build the neural net are generally technology companies, and they don't have the data to build it, right? Because as hospitals, I have been in the system, right? We don't trust the tech guys, of course, for good reason. For good reason, let me say that. The people who have the data, which is the clinical teams, right, typically don't have the quality of the engineering talent that can build the neural nets joining them, right? And so they're not able to build the neural net out. So if the institution that does clinical care is the institution that builds the AI and does that together, kind of like Tesla for healthcare, sort of like that, you can actually build systems that are that can actually start doing the early surgery work, and then eventually the more and more complex part of the work, and then kick it up to the human surgeon when they reach an exception, which allows surgeon 1 to supervise 100 surgeries rather than just do one. Kind of like how autopilot works, right? Like the interruptions from human become less and less, right? And that also is a vision-based system. This will probably take us 3 to 5 years to test this out and figure this out and build it. But if we do this, right, then, and when I say we, I mean somebody, hopefully us, but hopefully others. Then what you can do is you could basically build dark PHCs, because then that just becomes a capex outlay, simple capex outlay, right? And then people could come in and actually get the treatment, which is supervised by a great surgeon. Because no matter what we try and do, the reality of the world is that the great surgeons are very rarely going to go live in those areas. So they will always be sort of high quality dark areas. So the only way to do that is to put something there that can operate 24/7 under supervision, right? And over time, I think the automated system will get better and better. And then, we will, for example, if you see this company in the US called Neuralink, right? Neuralink does this today already for brain implants. So they do like full brain surgery in putting an implant into the brain, fully automated. Right, so the technology is already there. If you can do brain surgery, I'm pretty sure you can fix the knee. Right? The knee is probably less. I mean, I hope there are no orthopedists there, they'll beat me out of this. But, the brain is probably a little bit more delicate as an organ compared to the knee. So this is sort of like how we see over the next 3 years, 5 years, 10 years. But obviously, as I said earlier, sir, that for us, these use cases are a little bit more direct and straightforward. The complexity that we deal with is a little bit less in that sense. But would love to hear your perspective on, how do you see Agentic AI evolving? Of course, one part you mentioned is how do you sort of synthesize the brain interest of the senior doctors and make them more accessible to the doctors in the field, but perhaps there is more.
Yeah, I think for us, reducing friction at our doorstep or within inside is the most importance, to kind of make sure a patient journey in a large hospital like this, the patient is able to get the comfort of care that you've kind of set in, but within a system like this, which is on a different scale. which means agentic AI in insurance, we have 8 to 10 hour wait sometimes, we have other kind of challenges. So, and how do we, task shift within our organization? So use some of these, resources for much more human care and move a lot more into agentic care. So that's where we see, at least in the next 2 to 3 years, implementing some agentic AI in our systems. But I think now I'll open out for a couple of questions. I know I can see a lot of hands. Professor Moidu, you go first, and then perhaps Bharat, and then.
I don't know how to get this on.
I can hear you, sir.
You can hear me,
Yeah.
and I want others to hear it, because I'm going to share with you something you said about the way people think and the adoption goes. Today in America, we have in the University of California, at San Francisco, a Professor Robert Wachter. Robert Wachter was one of the earliest people who's a hospitalist who condemned the waste of time with an electronic digital record. And very few months after that, one of his residents killed a patient by giving them a very wrong dose, despite the AI alert coming to him, don't give this dose. It was a lady, sorry, so giving it to her. So after that, he sat down, reflected himself, and today he's the most progressive spokesperson for digitalization of healthcare. So I wanted to share that with people, that yes, people come skeptical because seniors do. I have been in the field since 1983. Okay, many of you were not born.
I was not alive then.
Yeah,
So
you're
I
not
did
born.
exist
I
then.
didn't want to tell you that, but I just want to tell you. But the fact was, many of the seniors give an attitude to the youngsters that I once had a chief resident who came to me, and I was distributing as far early in 1990 Apple Newtons to every doctor to document what they were seeing, especially with an aim to, in surgery, at end of shift, to pass the data to the next doctor so you don't waste time, so you can get home early. Guess what? We're trying to improve your life. No, that chief resident told me, everything your computer knows, I have it in my 3x6 card. So I looked at him, I said, fine. Then he went for an interview to a place, very hallowed institution called Stanford. And there when they asked him, oh, you are coming from Norwalk? Yeah. What's Moidu doing there? The guy said, he's helping us with informatics in residency. So he came running back. Early Monday morning, I find him outside my door. And I don't like people who don't like me, naturally.
That's fair.
So the gentleman comes into my office and says, I need 2 minutes of your time. I said, what do you want? I need a letter of recommendation from you. I said, you don't like my subject, and here in the Yale institution, you are trying to tell me you want a letter from me? Don't you know what I could write in that? I could write the one word that could kill your life, obstinate. He did show obstinacy. I mean, I was not wrong. And he says, what can I do to overcome that? So I made him write a book. How do you find a better job? You will put 3 tables in it, 4 decision trees, and list the issues one must think when they look for a job to settle with their families. He wrote that. A pharmaceutical representative printed it for me and gave it to all the residents as they graduated at Norwalk Hospital. And the point was he got converted. So what I'm trying to say basically is people can convert.
Oh yeah, for sure, for sure.
But it's a struggle.
Yeah.
It's a struggle.
Thank you, Professor Bharat.
Thank you. I'm actually going to repeat what Dr. Maj said. The problem of adoption, and I've been at St. John's with Dr. Tony closely, is not technology. It is essentially about people who have done some things a particular way for 30 years, and you're going to tell them to do it a different way. It's going to be very, very difficult.
Can I give some little bit of color on that, sir?
Yeah.
I feel that a lot of times, clinicians say and feel exactly what you're saying. I think it's a disservice to the clinicians, my personal opinion. See, look at the objectively a clinician. Okay, first, hardest and smartest person in 11th standard only could clear medical. Okay, like I couldn't clear it. So one, so smart guy, works hard. Second, he has figured out all the other technology. He has figured out the iPhone. God knows he's figured out Windows and PowerPoint. He has figured out surgical robots. Somehow he cannot figure out the HIMS system. Maybe it's the HIMS system. Yeah. Right? So the point I'm trying to make is the technology that has made its way over to the healthcare as an industry has been very, very low quality as software. If you look at the quality of software that other industries get to use, as an example, what a marketing team uses today in terms of how the ads are served or how the creatives get built or how the funnel gets tracked. And that's not even I have been a marketer all my life, but I can tell you, compared to a doctor, that's not even an important job. Okay, but they have access to such great tech, sure, right? That it's very easy and simple for them to do what they are trying to do, and therefore their willingness to understand and adjust to a new way of doing things is better. The problem is that usually all of technology that makes it to healthcare is basically a less and less pretty looking form fill. Sure. Okay, that's basically for the most part. And if that technology made it to any other industry, sir, I promise you there would be no adoption there also.
No, that's not what I meant. And I wasn't. We've had doctors like Dr. Thomas Matthew experimenting with me on Alexa back in 2017 to capture data. That's not what I meant. The change is required not at the clinician level alone. There are so many other people involved, and they've been doing things certain way.
Yes.
And they're just used to running those things in a certain way. And there will be an S-curve when they do something in a new way.
True. Agree, sir.
That was my point.
Absolutely agree. So I meant, it's a pet peeve of mine always, because I go to many conferences and I hear people saying that, oh, doctors.
I moved from .com to.
Okay, awesome.
Okay, the other question I had for you was, what do you use as the underlying schema for your system? Are you using OpenEHR or any other open source technology to build the...
So actually, what we did was a little bit different. What we did was we basically looked at the SNOMED as the coding, right? And we built it a little abstracted because it wasn't clear if at some point the government will settle on SNOMED or ICD-10 or HL7 or what. So we made it in a way that it is roughly interchangeable because we didn't quite know what to do. But what we did was the front end of that actually is a custom thing we have built for doctors' use. Right? So what we have is essentially an interface system to which you can just query things. Like you can just ask it stuff. Right? You can just say that, tell me what was the blood pressure yesterday. Right? Instead of us showing you a form or a way in which
so
you
a conversational engine on top of a CT.
Or it could, another one, sir, for example, all of the doctors at Superhealth to do care actually use Slack. Our front end is Slack.
Okay.
So every patient has a channel, and then in that channel, the entire care team is there. So we therefore, thanks to Instagram training people on doom scroll, we don't have to do handovers because everybody's in the channel. They can just like doom scroll at home. And so
we'll take this offline. I'd love to come and visit.
Share absolutely, sir. Would love to.
Sure.
So actually, I would bit with you. Over last year, we must have had about 700 hospitals in 12 different cities. Worked on finding out what the digital adoption was and eventually presented to the ecosystem is pretty bad, but there are a lot of people looking towards ambient.
Yes,
as
ambient
you said, to save the day. But the perception I got was that's horribly expensive. Right now, it's per user license or something. And I don't know if that's your own cost.
Probably, sir. We built everything ourselves.
Right.
So for us, the cost is pretty low.
Okay.
Like for the whole thing, we pay like, I mean, our tech cost for, I mean, for the AI systems is like 50,000 rupees a month type of thing. So it's like pretty low.
So the follow-up to that is, the current state of Super OS, how does it scale up to, say, a larger 500-bed tertiary multi-specialty hospital, maybe here as a destination place? Where are the gaps? Second, how does it apply to maybe a 75-bed hospital in a city like Indore, Bhopal? And what are the economics?
So actually, in general, if the hospital is of similar type, what I mean is, like, we cannot solve for something that sir was saying where a doctor is sitting and talking to 3 patients, right? Like, I think AI systems would, at least the one we have designed, would certainly struggle because it was designed for a more one patient to one doctor type of interaction, like what happens in urban centers. Now, in that, if it's a 500-bed hospital or a 50-bed hospital or a 75-bed hospital, wherever that type of hospital, it'll work. There's no issue. But if the mode of engagement changes, where, let's say you're in a PHC sort of setup and a doctor is talking to 10 people, I think at that point, our AI is not sophisticated yet to understand that. That being said, our AI today deduces the doctor and the patient rather than us saying this voice is the doctor. Okay, so it is a fairly intelligent system which can understand basis the conversation who the doctor is and who the patient is, and so it is not that complex to imagine that it can therefore be trained into understanding different patients, because it can have a in-session voice ID that kind of like tries to triage different patients. But we haven't built that yet. I mean, it's easy for me to sit here and say "Aasan hai," but wo tech team batayega. But it's not. It shouldn't be too difficult.
Next question.
Yes, sir.
Varun, I do not have a question. Not only my question, you have answered all questions of my fellow workers in my residential complex. Because all these days they were asking, what about this super hospital? So congratulations.
Thank you, sir.
And secondly, in a way, you have sort of incentivized falling sick also. In fact, you made us think about 2020-47 Vikasit Bharat or futuristic hospital on a true sense. Really. And thirdly, Dr. Atul was talking about the more of primary and the primordial care of that. So probably in that sense, we are in a sort of a loggerheads, actually incentivizing falling sick. Coming to my question, I'm a clinical pakka radiologist, clinician radiologist. So far, I had not heard anybody praising so much clinicians other than my mom. So thanks. Thanks to that as well. Last question. Like among all these branches in terms of implementation, because everybody was focusing about the change management, and that looks the true critical issue for us who have seen the change management. So what was the easiest branch? Was it radiology, as I expect?
Of course, sir.
Thank you,
No, I'll tell you, actually, with diagnostics, what we do is we have a partnership with United Imaging, which is a little bit of a different partnership than most of their other installations. Because we did a 100-center partnership with them, we get to work very closely with their president, founder and president, Dr. Shea. And because of that, we have a slightly different type of access to all their core data systems in the machine, the imaging data. So what we do is we actually pull all the raw imaging data and we run the analytics on top of that instead of being a traditional API type of thing. What that allows us to do is we build 2 important things on top of that with that data. We take that and we actually run the analytics and we present to the radiologist as a suggested thing, saying here is what we think. Of course, the radiologist has to finally see it, overrule it, whatever, and our radiologist goes through that and fair. So let's say it's a 160 slice CT that we've done. We'll sort of surface saying that these 5 slices look like where the issue is, but of course see the rest. Our clinicians then go through that and actually mark it. And as soon as the clinician directly marks it, our algo learns itself. Right? Everywhere else, the clinician has to accept the algorithmic change themselves. It doesn't automatically self-learn like in consults. Here, as soon as the radiologist deletes or adds anything, we learn it and it gets better. Secondly, and more importantly, what we have done is because we built it like this into our cloud's infrastructure, we are able to beam this across any device in an interactive manner. So we build the front end where you don't just get a plate or a view, you actually get a full 3D interactive version on your phone. You can just open it on your phone as a clinician, right? And that we believe is much better because now the radiologist, wherever they may be, right, even if it's an emergency thing, it's not like they have to come in or see some random photo on WhatsApp. They can actually see the full fidelity visual and make a good decision. The second thing that we're doing is that now that we've done enough of these scans, we are now starting to do the base draft of the report for the radiologist to see, is this what you agree with? And then they can basically put that in and send it out. Send it out. Once they approve and review it, they send it out. So again, our idea is that how do we minimize the repetitive tasks of the clinicians so that they can focus more and more on the sort of more interesting side of things, I guess, for lack of a better word. But that is the idea, sir.
Thank you. I know
Thank you
we've
so much.
come to the end, but maybe one more question, Dr. Talukdar.
Yeah, the question I have is that now, well, I don't need to re-emphasize it, but before that, let me congratulate for your thoughts and the way you are doing. Fantastic.
Thank you very much, sir. Very kind of you.
The question I have is that do you have any plans to make these findings of yours of reducing the cost and better care and avoiding many of those over proper anonymization?
Absolutely, sir. So, as I said, we're a pretty young institution. We're about 5-6 months old. So we want to at least finish a year, and then we will, have the full longitudinal data for a year, and then we'll start publishing some of these data sets, which will hopefully, help, other people see two important things. I think the first is that we have to demonstrate as a company that it is possible to build and deliver what we call honest healthcare. And I think it's equally important that we demonstrate that this is financially viable, right? Because only if both those two things happen, will the entire industry move to this system or this way of executing healthcare. Otherwise, it's very easy for someone to say, yeah, but we are a for-profit or whatever, and we can't really do what these guys do. So absolutely, but I think beyond even the clinical data, sir, what our hope is that in another year or two, once we have a few more centers, for this to sort of feel useful and meaningful, we will 100% open source all of our operation protocols, all of our business models, all of our tech, and just let people, like, I wish everybody, if we deliver what we think we're going to deliver, I wish more people just simply copy what we're doing. India is about 3 million beds short. We're not going to make 3 million beds, right? I mean, with my own founder optimism, 30 lakh bed thodi banayenge. So, let everybody make it. I mean, the more infra we have, the less the scarcity, the more access people will have. The more access people have, the better the care. And to what Sir was saying earlier, I do not believe that we will get to a developed nation in 2047 as a country unless we fix healthcare. We have to have a very robust healthcare system for India to have a meaningful shot at being a developed nation. And that is what our purpose is. That's what Superhealth is about. That, on the journey to being a, developed economy, how do we make sure that at least we can perhaps pick the part of healthcare and try and see how much we can improve it. Maybe demonstrate that it is possible. And it's probably less effort, less risky for us to do it because we are kind of like a cute little sandbox for the big guys to look at and say, okay, if they can do it here, why? Maybe it's possible, and there's no risk to them.
Excellent. So just a follow-up question. Now, while you take the case studies and many of them, you come about some of the retrospective information about the patient. Case history that 3 years ago this happened. So do you have any plans to make the cross-sectional data which you are having for the patient today into some kind of longitudinal data?
Absolutely, sir. And again, given the specificity around the DPDP Act and stuff and making sure we're compliant with that, ensure as far as we can ensure that, we would love to make this data available to everybody. People should add their data to this. We will certainly make ours available because ultimately India has to make this for itself, right? ये हमारा ही problem है. बाहर से आके कोई करेगा नहीं हमारे लिए और हमें उनकी ज़रूरत भी नहीं है. हम खुद बना लेंगे. And at least that is what our intent is. And ऐसा नहीं है ना कि वहाँ बहुत अच्छा चल रहा है. वहाँ तो जो हो रहा है वो यहाँ अगर होगा तो बहुत ही बुरा होगा. So let's just build our own system.
Thank you, sir.
Thank you guys. Thank you so much.